Hi guys, today we are going to discuss about pyogenic liver abscess. Let's get started. Talking about the etiology of pyogenic liver abscess, the infection to the liver can enter through two routes. One of them is portal vein. The second one is bile duct, and the third route is through hepatic artery. In this figure you can see the portal vein posteriorly, bile duct anteriorly and to the right, and hepatic artery towards the middle and anterior. So talking about the sources of infection or the route of infection, the first and commonest one is biliary tract. What happens is the biliary tract gets obstructed due to bile duct stones or tumors. So the bile inside the bile duct gets static and is a suitable medium for infection. The bacteria and necrotic tissue sets in, resulting into septic emboli. The septic emboli will attack the liver, thus causing multiple liver abscesses. This process is known as ascending cholangitis. The process of setting in of infection inside the bile duct due to bile duct obstruction is known as ascending cholangitis. Biliary tract is the commonest of all source. The second one is portal vein. Here we have portal vein which is formed due to the union of tributary splenic vein and ileocholic vein, which give rise to the superior mesenteric vein along with its tributaries. Here we have a mosaic appendix which, if get inflamed, will result into appendicitis. Thus the complicated kind of appendicitis will result into thrombophlebitis of ileocholic vein. The thrombophlebitis of ileocholic vein will cause septic emboli formation in the superior mesenteric vein. In turn, it gets transmitted upwards towards the portal vein, causing portal pyemia. The portal pyemia then attacks the liver, causing multiple liver abscesses. The third cause for the source of infection is arterial cause or hematogenous cause for abscesses. The reason for hematogenous cause is hepatic artery. It can be due to tonsillitis, bacterial endocarditis, IV drug abuse, and osteomyelitis. The last is idiopathic cause. The predisposing factors for pyogenic liver abscess is immunocompromised patient and already existing lesions, diabetes mellitus, leukemia, chronic illness, elderly, alcoholics, transplanted patients. For already existing lesion, we have hydatid cyst, Amoebic abscess, and hematoma that can act as predisposing factors. For causative organisms, we have different types of causative organisms for different route of infection. For bile duct, we have E. coli and other gram-negative organisms like Klebsiella and Proteus. For portal vein, we have streptococci and anaerobes. For hepatic artery, we have Staphylococcus aureus. Talking about the complications, there is direct extensions of the abscess. From liver, it can go to the pleura, causing empyema. It can go to the pericardium. It can go to the lung, causing other lung abscesses. It can go to the peritoneum, causing peritonitis. Talking about the clinical features, general manifestations like fever, headache, malaise, anorexia, right hypochondrial or lower chest pain, abdominal examination reveals tender hepatomegaly, which can reveal as abdominal guarding or rebound tenderness. Patient may present with pyrexia of unknown origin. Picture of causating lesion may present. For example, in case of cholangitis, it can present as charcot-triad. Charcot-triad is triad of pain, jaundice, and fever and rigors. In case of appendicitis, there is presence of migratory pain in the right iliac fossa. Talking about investigations, we have labs, imaging. In labs, we have leukocytosis. We find anemia and high ESR. Performing liver function test, there is low serum albumin. There is high alkaline phosphatase and high transaminase level. Elevated serum bilirubin is present in cases of cholangitis and multiple abscesses. CT and ultrasound can be performed for imaging, and even chest X-ray can be performed for confirmation. We can do aspiration for culture and sensitivity. This is ultrasound. The first one is the initial ultrasound of initial stage, where you can see the debris inside the abscess cavity. The second one is the late stage, where you can clearly see the liquefied pus inside the abscess cavity. Here you can see the low density lesions containing echogenic material, which is pus and necrotic tissue. In CT scan, we have two main signs that we can identify in case of pyogenic liver abscess. One of them is double target sign, in which there is central low attenuation lesion which is surrounded by a high attenuation inner rim and a low attenuation outer rim. We have a lesion, we have abscess cavity inside which is low attenuation lesion, and outside we have two rims. The inner rim is surrounded by high attenuation structure and the lower rim is formed of low attenuation structure. The second sign is cluster sign, which is aggregation of multiple low attenuation liver lesions in a localized area to form a single lesion. This is a pyogenic liver abscess in the right lobe of the liver, which shows hypodense rim secondary to peripheral inflammation. This is a low attenuation of the liver. Here we have a CT scan showing the rim, inner rim and the outer rim. The inner rim is a high attenuating and the outer rim is low attenuating. This is called double target sign. Here we have the cluster signs where there is multiple aggregation of cystic cavities. This is a CT scan. The first one is arterial phase, CECT, and the second is portal venous phase, CT. Here you can see the hypodense cystic lesions showing aggregations, which is known as cluster sign. In the portal venous phase, we can see the enhancement of irregular septa within the abscess cavity. So talking about the approach of the pyogenic liver abscess, if we suspect pyogenic liver abscess, the first thing we gotta do is we gotta perform ultrasound or CT scan. The second step we're gonna do is we're gonna send the blood and aspirate for the culture. The third thing we're gonna do is we're gonna send serum IgG or IgM ELISA for intra-amoeba histolytica test. Last thing we're going to do is start empirical antibiotics. So what are the treatment modalities for pyogenic liver abscess? We have mainly 3 treatment modalities. Number 1 is broad spectrum antibiotics. The second one is percutaneous guided drainage of pus, and number 3 is open or laparoscopic drainage, which is nearly replaced these days by percutaneous drainage. So talking about broad spectrum antibiotics, the first line of antibiotics is penicillin, aminoglycoside and metronidazole, or cephalosporin and metronidazole. Empirical antibiotic therapy is used initially, but later on it is replaced or it is changed according to the results of culture and sensitivity. Talking about percutaneous guided drainage of abscess, it is very simple, and it should always be guided. We should not perform percutaneous drainage of abscess without guidance of ultrasound or CT. So we can use ultrasound or CT for the guidance to direct needle towards the abscess cavity. We aspirate the abscess, then a tube is inserted. Here you can see a doctor performing the percutaneous drainage procedure of a liver abscess. You can see here the ultrasound picture of the liver abscess. The doctor is injecting some saline. Here you can see the needle passing into the abscess in the ultrasound picture. Here you can see the pus over here. The doctor is inserting the catheter through the guide wire. You can see here how the doctor is inserting the pigtail catheter through the guide wire. This is the pus which is aspirated. Thank you for watching this video. I hope you. Talking about the incidence of amoebic abscess, it is commoner than pyogenic abscess in third world countries that are also known as developing countries. They are especially present in those lying in the tropical and subtropical regions. Let's talk about etiology. Amoebic hepatitis or abscess is complication of amoebic colitis. In etiology, we should talk about three things: predisposing factor, causative organism, and the mode of infection. The predisposing factor here is low standard of hygiene and high humidity. Entamoeba histolytica is the causative organism. The mode of infection is ingestion of cysts with improperly washed vegetables. In intestine, what happens is the cysts are changed into trophozoites, inducing amoebic colitis. Here we can see the flag-shaped amoebic ulcer in the right and left side of the colon. This is superior mesenteric vein which drains the right side of the colon. This is splenic vein, and this is inferior mesenteric vein which drains the left side of the colon. The splenic vein and superior mesenteric vein combines together, forming portal vein. The portal vein in turn divides into the right and left branch into the hilum of the liver. The trophozoite from the right side of the colon runs upward through the superior mesenteric vein and reaches the portal vein, and through the right branch of the portal vein to the right side of the liver. Thus, the trophozoite on the right side of the colon will enter to the right side of the colon, right side of the liver. Right side of the colon to the right side of the liver. And the trophozoite from the left side of the colon transfers upward through the inferior mesenteric vein, through the splenic vein, into the portal vein, and through the left branch of the portal vein towards the left lobe of the liver. So, if there is amoebic colitis on the right side of the colon, there will be amoebic hepatitis or amoebic abscess on the right side of the liver. If there is amoebic colitis on the left side of the colon, there will be amoebic hepatitis or abscess on the left side of the liver. What usually happens is the amoebic colitis is more common on the right side, thus resulting into more amoebic hepatitis and abscess on the right lobe of the liver. Here, when parasite enters the right lobe of the liver, it will cause liquefactive necrosis, and thus it will form many small abscesses which in turn combines together, giving rise to single and unilocular amoebic abscess. Talking about the wall of the abscess, it is saggy, which you can see in the figure, the saggy shape, and it harbors amoeba. Here you can see the amoeba on the wall, and this here is the wall. Talking about the pus, it is sterile. The sterile nature of the pus is so because the amoeba is present in the wall, not in the pus. It is brown chocolate color and sometimes it is pinkish. Classically, it is described as anchovy sauce appearance. Talking about the site, it is present on the posterior superior segment of the right lobe of the liver. Here this is diaphragm, lung, pleural space, and here this is liver. Here you have right and left branch of portal vein. And here we have abscess on the posterior superior aspect of the liver. The segmental branch of the posterior superior aspect of the liver is in direct continuity with the right branch of the portal vein. Thus, making it the common site for the abscess. So now we are going to discuss about the complications of amoebic abscess. Let's discuss about the rupture. When it ruptures upwards, the first thing that's going to happen is formation of long abscess. Usually what happens is the pleural space is obliterated, thus lung getting affected earlier than that of the pleural space. If it ruptures into pleura, it will cause empyema. In pericardium, it can cause cardiac tamponade. In peritoneum, it can cause peritonitis, and it can rupture into any other intestinal organs. The most common complication is secondary bacterial infection. Another complication is calcification of chronic liver abscess. If the abscess rupture upwards into the bronchus, it can result in the formation of a fistula known as bronchopleural biliary fistula. It can rupture outward, resulting into pointing below the costal margin. It can spread through the blood, resulting into Pyogenic Amoebic abscess. The last complication is destruction of the liver with liver cell failure and ultimately death. The clinical features, we talk about history, general picture, local picture, and the picture of complications. In history, we will find the history of amoebic colitis in most cases, but it's not always obtained. Low-grade fever is present with other constitutional manifestations like anorexia, nausea, weakness, and weight loss. Patient is usually pale and toxic, thus giving an earthy look. For memorization purpose, you can memorize it through this diagram, which gives you the imagination of the earth, the picture of the globe in this diagrammatic representation. Talking about the local picture, there is upper right abdominal pain, usually tender hepatomegaly, tenderness in right intercostal spaces. Patient may have right-sided pleural effusion and basal lung collapse. Here we have a diagrammatic representation. This is effusion and the collapsed lung. This you can see here the tenderness in right intercostal spaces and the tender hepatomegaly. Thus, what you can see from this diagram is the patient has earthy look with right-sided pleural effusion and collapsed lung, tenderness in the right intercostal space, and tender hepatomegaly. Talking about differential diagnosis, we have pyogenic liver abscess, acute cholecystitis, perforated ulcer, acute viral hepatitis, pyelonephritis, and hepatocellular carcinoma, especially in black Africans, which assume a rapidly progressive course with pain and constitutional symptoms. In investigations, the first we have is stool analysis and serological tests, which may be ELISA. In non-endemic areas, it is very useful, but in endemic areas, it is positive in almost all of the population, so it is not that useful. The second one is blood picture, which will show leukocytosis and anemia. Imaging can be done like ultrasound, CT, which is very useful, and chest X-ray. Therapeutic test can be performed by using metronidazole. An improvement in local and general complications after 3 days confirms the diagnosis. This is a X-ray picture of amoebic abscess. You can see here the elevated right cupula of the diaphragm and haziness on the lower lung field denoting pleural effusion. Here we have ultrasound picture of amoebic abscess. It shows a homogeneous hypoechoic lesion with a smooth wall. This is the characteristic for amoebic abscess. We can differentiate it from pyogenic abscess, as pyogenic abscess may be smooth wall or it can have irregular wall, and amoebic abscess is always homogeneous, while pyogenic abscess is heterogeneous a lot of the time. This is another ultrasound picture which is taken after metronidazole therapy. Here you can see the smooth wall of the ultrasound abscess, outer wall of the ultrasound. We see the saggy wall of the abscess, which is very characteristic, and the hypoechoic homogeneous lesion resembling pus. This is a CT scan. We can see here the single and unilateral abscess, which is most probably amoebic abscess. The content inside is homogeneous, and we have here the double target sign, which is characteristic for hepatic lesions. The inner rim is highly attenuated and the outer rim is low attenuated, showing the difference. This is another CT picture of late stage liver abscess, which is large. Here this is on the posterior superior aspect of the liver, right top of the liver, thus denoting the amoebic abscess. Talking about the treatment, we have three modalities: conservative treatment, ultrasound guided percutaneous drainage, percutaneous aspiration, and open drainage. Conservative treatment is highly successful. Metronidazole is the drug of choice. 800 mg 3 times daily for 7 to 10 days will do the job. Other drugs used are tinidazole, ornithazole, and for cyst eradication we can use diloxanide furet and paramomycin. Ultrasound guided aspiration, we have 4 indications for aspiration in case of abscesses. We have A, B, C, and localized intraperitoneal abscess. For A we have amoebic abscess, B brain abscess, and C cord abscess. The indication here for aspiration is for the abscesses that fails to respond to treatment within 72 hours, and for large abscesses the method is by a large bore spinal needle under local anesthesia. We can see the needle here. For site of aspiration, the ultrasound guided aspiration from the front is the ideal site for aspiration. For anterior abscess, the needle is inserted below costal margin, and for unknown site, in the previous days, aspiration was done through the 8th intercostal space in the mid-axillary line. For the posterior abscess, needle is inserted through the 10th intercostal space. Few days later, ultrasound is repeated, and if the abscess cavity has recollected or if the abscess is more than 5 cm in diameter, aspiration is repeated. The third modality is open drainage. The indications for open drainage are presence of secondary infections or complications, dangerous complications, if the abscess is pointing, if aspiration is difficult because of multilocular abscess or the presence of pus. Here we have abscess on the posterior aspect of the liver. For the posterior abscess, we take a subparietal resection of the rib, the 12th rib, and we lift the pleura upward thus draining the posterior abscess posteriorly. This approach is termed as subperiosteal and extrapleural approach. For anterior abscess, we can see here this is peritoneum forming peritoneal cavity. There are adhesions present. So this is the abscess. So we just make an incision and drain the anterior abscess from the subcostal region, and by extraperitoneal approach. We don't open the peritoneum, rather we deal with the peritoneum here. And the last approach is transperitoneal, which is used very rarely these days. Here we can see the exposed abscess.
Guys, hydatid cyst, the morphology may be asked, okay? So just pay attention here where we are. We're looking at this Echinococcus granulosus. This is a cestode, helminth cestode. It is going to cause something called as a hydatid disease. It has an egg and it also has a hydatid cyst, which has the larva inside, okay? This is actually called as dog tapeworm because it's found in dogs. It has a scolex. Can you see it has a scolex, right? With hooklets, it has scolex, right? And a neck and all that. So basically, after entering the definitive host, right, the scolex can become exvaginated and develop into adult worm. However, now we are looking at the cyst, okay? We are looking at what? The hydatid cyst. Now, what is the morphology of the hydatid cyst? So basically, you can see three circles you have to draw, 1, 2 and 3, okay? The outermost circle you will call it as pericyst, then ectocyst, then endocyst. Endo is inside, remember here ecto is not outside, ecto is intermediate and pericyst is outside, okay? 3 layers over. Then inside something you have like this, which is attached with a stalk, right? These are brood capsules. Inside them you have what is scolex, okay? These are brood capsules, there's a stalk and inside it you have scolex. Understood, right? Look at it more closely if you didn't understand. There are brood capsules here which have stalk attached to the endocyst, okay? Then here you have what is called as a daughter cyst. This is not attached anywhere, it doesn't have a stalk. Then you have a daughter cyst which has nothing inside. That's a sterile daughter cyst. Then you have hydatid fluid, guys. This entire thing, whatever you see here, all this is hydatid fluid. And then you have something called as hydatid sand in the hydatid fluid. This much did you understand? This hydatid fluid itself is going to be extracted for Cassoni's test. But here what we are focusing on, we are focusing on the hydatid cyst morphology. This is usually found in the liver, right? This endocyst is there, right? This is the germinal layer, okay? This is the vital layer. Then hydatid fluid, what you will have here, this hydatid fluid is the clear colorless or pale yellow fluid called hydatid fluid. It's acidic. Inside this you will have the hydatid sand, which is granular deposit, okay? It consists of free brood capsules, okay? Now what are brood capsules? Brood capsules, we told you this is a brood capsule. Now brood capsule basically from the germinal layer, small knob-like gemmules, they protrude into the lumen of the cyst, okay? These enlarge, they become vacuolated and filled with fluid. These are called as brood capsules. So they protrude from this germinal layer, okay? These are the brood capsules. So inside the mature hydatid cyst, there will be a daughter cyst and granddaughter cyst, okay? So here you have the daughter cyst, etc., right? Granddaughter cyst, daughter cyst you can have. These hydatid cysts, right, the fate of these, they can get calcified or they can spontaneously get evacuated following inflammatory reaction. Okay, but it may rupture into the lung and other body cavity, producing disseminated hydatid lesions. So that is all about the hydatid cyst morphology.